Bismillahirrahmanirrahim. Assalamu alaikum. My name is Dr. Muhammad Mashkoor Aslam, resident of Urology at SIUT. So today's discussion topic is central venous access catheter infection and how we can avoid them. Learning objectives of today's discussion are introduction to the double lumen catheters and how to insert them and how double lumen catheters are infected and ways to prevent infection and that are related to double lumen catheters, and finally take home message. First of all, introduction. So double lumen catheters are those catheters which are used for exchanging the blood to and from dialysis machine and patient, and for this purpose AVF are the first choice, but they usually take time for maturation. So meanwhile we can use catheters and double lumen catheters for this dialysis. The catheters should be used in these patients who are in acute need of hemodialysis. There are usually two types of catheters, temporary and cuffed catheters. So indications of these double lumen catheter insertion, first of all is acute renal failure, then end-stage renal disease who are requiring hemodialysis, and also end-stage renal disease who don't have any angioaccess, and patient having acute kidney injury or dialysis for overdose, and transplant patient who require hemodialysis before transplant. There are also some contraindication to double lumen catheter insertion. For example, if there is a distorted anatomy due to some trauma, then we have to avoid that site. And also if there is some infection, obvious infection at the catheter insertion site, then we should not use that site for dialysis catheter insertion. And also if there is some proximal vascular injury or thrombosis in the vein, then we cannot use that site as well. Also, if the patient is having some bleeding disorder on anticoagulant, then we have to be very careful while inserting double lumen catheters. So as I have previously mentioned, there are two types of catheters. First is the temporary non-cuffed and second is cuffed tunnel catheters. This image shows the temporary non-cuffed catheter. It has been inserted in IJ vein, and it is shown clearly, and it is ending at the point where superior vena cava is entering into the atrium. Then is the tunneled cuff catheter. This is entering at the skin where it is labeled as vein entry point, and this is tunneled under the skin as this is shown here, and then entering similarly as the non-cuff catheter into the IJ vein and into the superior vena cava. Then there are some advantages of catheters. These catheters provide time for fistula maturation, and they are universal in application. They can be applied anywhere. They don't need maturation time. They can be used immediately after insertion, and they have lower initial cost. There are some disadvantages as well, and they can cause infection. They can lead to thrombosis of the vein. They are some discomfort and have some cosmetic disadvantage, and also they have shorter expected using time.
What is the difference between two catheters? What is the basic difference between two catheters? One is the short term and the long term.
The long term are usually tunneled catheters, and they are cuffed, and they have low rate of infection, so they can be used over a long period of time, and they can be used up to 6 months. And short term, they can be used for only 1 to 2 weeks.
So why there is decreased chances of infection in
Actually those who are tunneled catheters and they have a cuff, the cuff is the site where it inhibits the entry of pathogens into the tunnel, and that's why it has low rate of infection. Whenever a cuff catheter is placed, it get dilated and it blocks the entry of pathogens from the skin.
So there are two ways of entry of pathogens basically. One is through the catheter and other is from around the catheter. So this long-term tunnel catheter, this decrease the chances of pathogens that travels around the catheter, but this does not decrease the chances of infection through the tunnel. So we need to take the same precaution as for the short-term catheter to avoid the infection in those patients who have a DL for the dialysis. So we need to opt all these options, preventive measures to decrease the chances of infection in these patients.
Yes, sir. So moving forward, catheter location. Catheter can be inserted into a right IJ vein, left IJ, and similarly both femoral veins can be used and subclavian. However, subclavian should be avoided for the risk of venous stenosis.
What is the difference between the IJ and femoral catheter? Is there any difference or the same size you can use in both sides?
IJ has a shorter length, while femoral catheters are of more length because we have to take that catheter up to the inferior vena cava. That's why femoral catheters are of larger length. So how to insert a double lumen catheter? First of all, we have to prepare that area and anesthetize it. For this, we use ultrasound to localize the IJ vein, and then we also note the carotid artery, its relation to the IJ vein. Then we clean the mid and lower neck with the iodine solution and drape the patient. Then we inject the lidocaine into the skin at the insertion site and turn the head of the patient towards opposite side. For instance, if we are inserting into the right IJ vein, then we will turn the head of the patient toward left side. Then the technique, using a 18 gauge finding needle, we will insert at the tip of the jugular triangle at the 45-degree angle to the skin and pointing or aiming towards the ipsilateral nipple. We will use ultrasound guidance with the portable ultrasound and to locate this vein, and we will also look for the carotid impulse, and carotid impulse should be medial to it, and we will go laterally. And while inserting the catheter and this guiding needle, we will pull the plunger so as we progress. So whenever a flash of blood with the dark blood is coming, this indicates that we have entered the vein. This is the jugular triangle. It has two heads of the sternocleidomastoid. This is the lateral and medial head, and this is the top or tip. And we will insert and the needle at this point. This carotid artery is lying medial to this. So once we are in the vein, then we will steady the needle and gradually withdraw the needle and steady the needle in the vein. Then we will remove the syringe and insert the guide wire. And if there is some resistance, then we don't force it because it can be dislodged. And then we holding the guide wire, we will remove the needle and then make a small nick with the help of 11 number blade, and the nick will be given at the point where the guide wire is entering the skin. I will elaborate these points with the help of diagram in the upcoming slides. Then we will advance the dilator over it. With the twisting movement, there will be slide resistance, and then removing the dilator, there will be some gush of blood. So to avoid that bleeding, we will place a gauze piece, and then we will place the catheter. While placing the catheter, we have to take note that the guide wire must come out of one port of the double lumen catheter before inserting the catheter. Otherwise, the guide wire will also go inside the vein. Then we will remove the guide wire and flush both ports of the double lumen catheter with normal saline, and then fix with the help of silk suture. And then we will advise chest X-ray for the confirmation of the correct placement of this double lumen catheter. It should be ideally at the junction of superior vena cava and right atrium. So this Seldinger technique is used for the placement of this double lumen catheter. First of all is the needle puncture. We puncture with the help of a needle, then steady the needle in the vein, and a flash of blood is coming within the syringe. Then the syringe is removed and needle is hold in place. Then we will cover the needle to avoid excessive bleeding, and then we will advance the guide wire through the needle over this needle, and then we will remove the needle and holding the guide wire. Then we will give a small nick with the help of blade, 11 number blade at the point where this is entering the skin, and then we will advance our dilator over guide wire, and then removing dilator and placing our double lumen catheter over this guide wire, and finally removing the guide wire as well.
What is the ideal diameter of double lumen catheter?
12 to 14. So complications of double lumen catheter, and some complications are, for example, arterial puncture can occur during this placement of double lumen catheter. There can also be a venous perforation, and there can be bleeding or hematoma at the site, and it can also lead to pneumothorax or hemothorax if a pleura or lung has been ruptured, injured during this insertion, and that can also cause the infection and bacteremia, and double lumen catheter may be blocked. So how double lumen catheters are infected? For this purpose, we need to understand that there are various factors, and that can be categorized into four main categories. First of all are the host related factors. Host related factors are those, for example, in which the host is responsible for this infection. For example, if he has impaired immunity, or he has poor personal hygiene, he use occlusive dressing has been used, or he is older age, diabetic, and recent hospitalization. All these are the host related factors which are responsible for infection. Then comes the catheter related infections. The catheter, for example, the site of infection, site of insertion. If the femoral vein is used, then there are increased chances of infection as compared to IJ vein. And similarly, if the catheter is in situ for a long duration, then there are increased chances of infection. Also, history of bacteremia is some leading factor, and colonization of the catheter tip with the skin flora is also responsible for infection. And the most important point I want to highlight is the lack of aseptic measures, which are not dealt with in a proper way. Then this lack of aseptic precautions can also cause catheter related infection. Then some points are the pathogen related factors, for example, biofilm formation or resistant to antibiotic or bacterial virulence. They can also cause the infection of the catheter. Then some dialysis procedure related factors are also there. For example, contamination of the dialysate or inadequate water treatment, they are also responsible. And dialyzer reuse can cause the catheter related infection. Then are the evaluation and diagnosis. For the evaluation and diagnosis, the threshold for the infection, catheter related bacteremia, should be low. We must immediately think of it if some patient comes with the sign symptoms. And two blood cultures should be drawn, one from the peripheral vein and one from the central vein, and both sent for the blood cultures for the diagnosis. Then some clinical manifestations of these infection. These patients usually present with fever and with or without chills, and then there can be prevalence of the catheter insertion site. That can be erythematous, that can be edematous, and there some hemodynamic instability. There can also be hypothermia. Catheter can be dysfunction, cannot be working properly, and there is some acidosis, hypotension. These are the main clinical manifestations. Then there is an article which was published in 2018 by American Nephrology Nurses Association. This article also highlight the increased rate of infection. There are various points. There are total 96 patients in this study, but I will stick to more related to our today's discussion. And the catheter which were implanted into the femoral vein were approximately 56%, and approximately 10% of those who were infected, they were infected because of the catheter site infection. Then the result, It is broadly divided into various categories, but I will stick again to this infection related point. And what I want to highlight here is that femoral vein bloodstream infection were approximately 32.9%, whereas jugular vein infection rate was 18.7%. So those in which the femoral vein was used for double human catheter insertion, their infection rate was approximately double as compared to those in which the jugular vein was used. Then there is a table in this study which highlights that infection was the leading cause of death in all these cases. Approximately among 96%, 20%, 20 patients died, and they were died because of infection. Infection, which is a preventable cause. So we must avoid and we must take care of this infection, and I will describe this in upcoming slides. So for the prevention of infection, there are various guidelines were presented by CDC, and they were first presented in 2011 and then updated in February 2017. So number one point is education and training of staff. So the staff which is employed designated in this NGO access, they must be properly trained personnel. And then comes the hand hygiene and aseptic technique. Proper aseptic techniques and hand hygiene should be observed, and this hand hygiene should be done before and after the insertion of catheters, and we must also use sterile gloves and before insertion of these catheters. New sterile gloves should be used before guide wire exchange procedures. When we are exchanging the catheter over guide wire, then we must also use sterile gloves. Then maximal sterile barrier should be used, for example wearing a cap, mask, sterile gown, sterile gloves and full body drape, and these protocols must be observed while inserting the double lumen catheters and also while exchanging over guide wires. Then comes the skin preparation. The skin must be cleaned with the 0.5% chlorhexidine, preferably. If chlorhexidine is not available, then we can also use tincture of iodine and 70% alcohol as an alternatives. And the important point which I want to highlight here is the antiseptics should be allowed to dry before proceeding. Then central venous catheters insertion. Uh, Whenever there is adherence to aseptic technique is not ensured, then we should replace the catheter within 48 hours. And we must also avoid femoral vein, as there is increased chances of infection due to femoral vein. And also we should avoid subclavian vein due to the risk of the subclavian vein stenosis. And finally, fistula should be used preferably if the fistula or graft is there in a patient or chronic renal failure. Catheter site dressing regimens, we should use sterile dressing, sterile and transparent semi-permeable dressing. And then if there is a bleeding from the site of catheter, then we should apply a gauze dressing until the bleeding is resolved. If still there is oozing, then we can use a help of a stitch around the catheter to stop the bleeding. And while replacing the catheter dressing, the dressing should be replaced whenever it is damp, loosened and visibly soiled. And dry catheter site and place a new dressing whenever showering is used. So coming to the last slide, take home message. Take home message is radiologically placement of catheter is more reliable and it has got fewer complications. And also the double lumen catheter should be removed as early as possible when there is no need of dialysis. And we should plan AVF as early as possible to start dialysis after maturation. And we should recognize infection early, having low threshold for the catheter related infection. And we should use antibiotic and preferably broad spectrum antibiotics covering both gram positive and gram negative bacteria. Thank you.